Welcome. I am Assistant Professor Dr. Farhad Mustafa Musa Atrushi, and today we are analyzing the physiological mechanisms behind a highly common yet frequently misunderstood clinical presentation, refractory hypovitaminosis D. The standard clinical scenario is familiar to all of us. A patient presents with low circulating vitamin D. In response, we prescribe a standard high-dose course of vitamin D2 or D3 supplementation to correct the deficit. Yet weeks later, the follow-up lab results show a blunted, inadequate increase in serum 25-hydroxyvitamin D. The patient's skeletal mineralization parameters fail to improve. The supplementation appears ineffective. Clinicians routinely treat this as a primary supply problem, assuming the failure stems from a lack of sunlight, poor dietary intake, or poor patient compliance. However, vitamin D metabolism is not an autonomous process. Its transport through the bloodstream, its enzymatic activation, and its receptor binding are all strict, obligate magnesium-dependent processes. Establishing intracellular magnesium homeostasis is a physiological prerequisite for vitamin D therapy. Without this cofactor, the metabolic machinery required to process the supplement remains essentially dormant. The immediate clinical defense is usually the lab report. The assumption is that the patient's magnesium levels are sufficient because their standard serum magnesium panel returned normal results. To understand why, look at total body magnesium. Nearly 60% is in bone, 40% is intracellular, and only 0.3% is in blood serum. The body maintains tight control, aggressively pulling magnesium from tissue and bone to keep serum stable. This creates a specific physiological state known as chronic latent magnesium deficit. Once serum magnesium drops, the toll is severe. The body cannibalizes its own skeletal structure to maintain that 0.3% serum illusion. Relying solely on a serum magnesium test guarantees misdiagnoses. It allows a profound tissue-level deficiency to quietly perpetuate the patient's vitamin D resistance. Let us trace the biochemical failure point of vitamin D in the bloodstream. Whether synthesized in the skin as cholecalciferol or ingested orally, these molecules possess no intrinsic biological activity on their own. Notice that both sunlight exposure and dietary supplement pathways converge. These inert precursors must be mobilized into the circulatory system by binding to a primary carrier molecule, vitamin D binding protein, or DBP. Note the blue magnesium ion attached directly to the carrier complex. The structural activity and binding capacity of DBP is entirely dependent on the presence of magnesium. Without adequate magnesium to activate these carrier proteins, massive oral doses of vitamin D cannot be effectively transported. Your prescription fails at the earliest step of the journey, stranded before it ever reaches the liver. Even if a fraction of the cholecalciferol successfully reaches the liver, it immediately hits the next phase of metabolism, conversion by the hepatic enzyme 25-hydroxylase. This enzyme strictly requires a magnesium ion within its catalytic site to successfully hydroxylate the precursor into 25-hydroxyvitamin D. The newly formed metabolite then routes to the kidneys. Here, it faces its final conversion into the biologically active steroid hormone via 1-alpha-hydroxylase, or deactivation via 24-hydroxylase. Notice that both of these critical pathways are explicitly tagged as magnesium-dependent. When the body is in a state of chronic latent magnesium deficit, both the activation and deactivation enzymes suffer a complete functional halt. At the microscopic level, the precursor and enzyme may physically collide, but because the essential cofactor is missing, no catalytic reaction can take place. The activation pathway is a strict dual bottleneck. A magnesium void at either the hepatic or the renal stage guarantees a failed clinical outcome, leaving only inert precursors floating in the plasma. The disruption extends beyond the liver and kidneys. We must zoom out and examine the broader systemic feedback loop, specifically looking at the parathyroid glands. Magnesium deficiency operates as an independent variable that blunts the synthesis and secretion of parathyroid hormone, or PTH. Simultaneously, this deficiency reduces the expression and availability of vitamin D receptors on target cells across the entire body. Low magnesium triggers low PTH, which in turn diminishes receptor availability, severely degrading overall calcium and phosphate homeostasis. Magnesium deficiency halts the production of active vitamin D. It leaves the endocrine system unresponsive to the minimal hormone that manages to reach the target cells. This biochemical blockade is not a rare edge case, it is a widespread baseline condition. Anne Haynes' data reveals that nearly half the population in the United States consumes below the estimated average requirement for daily magnesium. Because of modern food processing techniques and agricultural soil depletion, clinicians must assume suboptimal magnesium status in their patients from day one. The mandatory clinical protocol is very straightforward. In cases of established osteoporosis, a blunted PTH response, or refractory hypovitaminosis D, simultaneous oral magnesium supplementation must be prescribed alongside the vitamin D. Targeting the recommended daily allowance of 310 to 420 milligrams per day ensures the intracellular space is saturated, enabling the enzymatic activation of exogenous vitamin D. Here is the expected success of the new protocol. Instead of stubbornly low 25-hydroxy vitamin D, we see appropriately corrected serum levels, along with stabilized bone turnover markers, like osteocalcin. Once the active 1,2,5-dihydroxy vitamin D is finally synthesized, it will naturally stimulate further intestinal magnesium absorption. This initiates a feed-forward loop that accelerates the patient's physiological healing. Treating vitamin D deficiency requires treating the entire biochemical environment. We must shift our approach from forcefully treating a single symptom to systematically resolving the underlying cellular blockade. Thank you to my medical colleagues for attending this clinical breakdown.